Welcome back to The Deep Dive. Today, we're on a pretty fascinating mission.
We are.
We're taking a stack of research on tinnitus, that maddening ringing in the ears, and tracing it back to a place most people don't even think about.
That's right. Not the inner ear, not noise damage, but a tiny piece of plumbing.
A piece of plumbing that connects your throat to your ear.
The eustachian tube. A lot of our sources today point to this as a huge and often overlooked cause of that noise you might be hearing. It's called eustachian tube dysfunction, or ETD for short.
Okay, so let's start right there with the basics, the anatomy. I know there's one in each middle ear, right behind the eardrum. But how small are we actually talking here?
Oh, incredibly small. And very sensitive. On average, it's about 36 millimeters long.
So just over an inch and a half.
Yeah, exactly. And what's really critical is its structure. It's not all the same. The part closest to your nose and throat is soft cartilage, and the rest is rigid bone. And that mix of hard and soft tissue is really important for how it actually works.
And it has a few different jobs, doesn't it? It's not just one thing.
No, it wears three main hats, you could say. All of them are crucial.
So what's number one?
The most famous one is pressure equalization. Making sure the air pressure in your middle ear matches the pressure outside.
That classic ear-popping feeling when a plane lands.
That's the tube doing its job perfectly.
Yeah.
Second, it ventilates the middle ear, which needs to be an air-filled space to work right.
On the third?
It's a tiny drain pipe. It has to clear out any fluid or secretions that might build up, say, from a cold or sinus infection. If that drain gets clogged, that's where the problems start.
Right. And the key thing, which I found fascinating, is that these tubes aren't supposed to be open all the time.
No, not at all. They're designed to stay closed almost all the time.
And they only open for a split second.
Exactly. When you swallow, or chew gum, or yawn, those muscle actions briefly pull the tubes open to let the air pressure equalize, and then they snap shut again.
Okay, so let's unpack this. That's how it's supposed to work. What happens when it fails? When we get this dysfunction?
Well, the sources are really clear that NTD is what happens when that precise open and close mechanism breaks down.
It creates a pressure problem.
A huge pressure problem in the middle ear. And that breakdown really falls into two main opposite categories.
Two categories, and it's really important to know the difference.
Yes. The most common one is obstructive ETD. That's when the tube doesn't open like it should. It's sticky or blocked.
So pressure drops, fluid builds up.
Exactly. And then you have the complete opposite, which is called patulous ETD.
Patulous?
Yeah, it means the tube stays open or patent most of the time when it's supposed to be closed.
And there's a third, more specific type, isn't there?
There is. Barochallenge-induced ETD. It's very similar to the obstructive type, but it's specifically triggered by really sudden changes in atmospheric pressure.
Like scuba diving or skydiving?
Or even just a really fast descent in a plane. It's when the tube just can't keep up with the rapid pressure change.
So we know these tubes are super sensitive to getting blocked. What are the usual culprits behind that inflammation?
The vast majority of cases trace back to inflammation in the nose and throat.
Things like chronic allergies, sinus infections?
Yep, sinusitis, pollution, even cigarette smoke. Anything that causes that soft cartilaginous part of the tube to swell up is going to block it.
But this is where our sources had a real aha moment for me. We all expect colds and allergies, but the list of causes goes way deeper. It links ETD to things that seem totally unrelated, like stress.
This is where you have to connect it to systemic inflammation. I mean, chronic stress isn't physically blocking your ear tube.
Right.
But the high cortisol levels that come with it can drive inflammation all over your body, including the mucosal linings in your throat and nose.
So that constant low-grade swelling is just enough to mess with that tiny opening.
It can be. It catches those sensitive tubes in the crossfire.
And even more surprising was the link to weight loss. How on earth does losing weight affect your ears?
It's so counterintuitive, isn't it?
Yeah.
Rapid, significant weight loss can actually contribute to the patulous type of ETD.
The one where the tube stays open?
Yes. And the reason is structural.
How so?
There's fatty tissue, adipose tissue, that naturally surrounds the soft part of the tube. It provides support.
Like packing material.
A good way to put it. If you lose a lot of weight quickly, that tissue shrinks, the support disappears, and the tube can just sort of fall open.
So it's a structural failure, not an inflammatory one.
Exactly. A fascinating distinction.
And that split between structural and inflammatory really explains the next part, the symptoms. What a person actually feels is completely different depending on whether the tube is stuck open or stuck closed.
The symptoms are almost diagnostic.
Yeah.
If the tubes stay open, that patulous ETD, you get symptoms related to hearing too much.
Tinnitus from inside your own head. It's called autophony, right?
That's the term, yes. Autophony, hearing yourself.
So what does that sound like?
Your own voice, your breathing, even chewing. It all sounds incredibly loud and altered, like a microphone is on inside your head. People report hearing the blood rushing in their ears, or their voice sounding like it's in a barrel.
That sounds absolutely maddening.
It can be.
Now let's contrast that with a more common problem when the tube is stuck closed.
The obstructive type, that's when you get all the classic pressure symptoms.
Fullness, pain.
A really deep feeling of fullness and pressure, sometimes pain, and often your hearing gets muffled.
And what's happening there?
If the tube stays blocked, the air inside the middle ear gets absorbed by the body, and it creates a vacuum. Negative pressure.
And that vacuum is dangerous. It starts pulling fluid in.
That's the big complication.
Yeah.
Otitis media, fluid in the ear.
Our sources really stressed this risk.
They should. That fluid buildup is called serous otitis media. At first, it's just fluid.
Yeah.
But if it stays there,
It gets infected.
it becomes the perfect breeding ground for bacteria, and then you have a painful, full-blown ear infection.
So it can escalate from just being uncomfortable to a serious infection very quickly.
And if that pressure from the infection isn't relieved, it can build up so much that it actually ruptures the eardrum.
A perforated eardrum.
A tympanic membrane perforation.
Right.
It causes a sudden, sharp pain, and then you might feel fluid or mucus actually draining out of your ear.
And that's not even the worst case scenario.
No, the infection can spread from there to other parts of the inner ear or even the head.
So the stakes are pretty high if you ignore it. And besides pain, people also get that constant annoying popping or clicking, and sometimes even balance problems.
All related.
But now, here is where it gets really interesting. How does all of this, the pressure, the fluid, translate into the sound of tinnitus?
This is the core of it. And the link is so distinct because there are two completely different ways ETD causes tinnitus.
And they line up perfectly with whether the tube is open or closed.
They do. So let's start with the blocked tube, obstructive ETD.
Right. Why does a vacuum in your ear make a noise?
The theory is that the chronic negative pressure is physically affecting the tiny blood vessels, the vascular structures, in the middle ear.
So it's squeezing them.
It could be squeezing them or just changing the acoustics of the whole middle ear space.
Yeah.
The ear is basically under stress.
And that stress creates a sound, a thumping or a humming or a roar.
Exactly. It's like a physical pressure alarm going off.
Okay, now let's flip it. What about the open tube, the patulous ETD?
With that one, the tinnitus has nothing to do with pressure. It's all about acoustics.
Sound travel.
Because the tube is always open, it creates a direct, uninterrupted channel from the back of your nose and throat straight to your middle ear.
So sounds from inside your body, which are normally blocked off, suddenly have a clear path to the eardrum.
Yes. That's why the tinnitus people hear is their own body. Their pulse, their breathing, their voice, all amplified and distorted. The sound is real, but it's not supposed to be audible.
What a critical distinction. So if you hear a roar, think pressure. If you hear your own body, think open tube.
It's a huge clue to the underlying problem. It absolutely is.
And who is most likely to get this? I think most people assume it's adults who travel a lot.
That's a common thought, but it's not quite right. While adults get it, children are actually far more likely to have chronic, recurrent ETD.
Really? Why is that? Is it just because they get more colds?
It's mostly anatomy. The geometry is just different.
How so?
A child's eustachian tubes are much more horizontal, almost flat. An adult's tubes are angled downwards toward the throat.
So gravity helps the adults.
A lot. Think of trying to drain a pool with a flat hose versus one angled sharply downhill. The child's tube is always fighting physics, which makes it so much easier for fluid to just sit there.
That's a fantastic analogy. So adults are more likely to get the acute pressure change related type.
Correct. The Barrow challenge-induced ETD or chronic issues from long-term allergies.
So when these symptoms just won't go away, how does a specialist figure out what's going on inside such a tiny space?
Well, it starts with an ENT, an otolaryngologist. They'll look in your nose for inflammation, and then they'll look at your eardrum to see how it moves.
They make you do that thing where you plug your nose and blow, right?
The Valsalva maneuver, yes. They watch to see if the eardrum moves, which tells them if the tube is opening at all.
But the real proof comes from the audiologist's office.
Yes, with specialized testing. They'll do a hearing test, of course, but the key is tympanometry.
What is that exactly?
A tiny probe goes in your ear canal, and it measures how the eardrum moves in response to very slight changes in air pressure.
And that gives them a definitive answer.
It does. An abnormal result immediately shows if there's negative pressure or fluid or even a perforation. It's the clearest picture you can get of what's happening in the middle ear.
Okay, now for the really good news. As awful as all this sounds, the sources all agree the prognosis is usually very good.
It is. Most of the time, ETD is temporary. It clears up on its own in a week or two as the congestion goes away.
But the key is not to let it linger.
Absolutely. If it lasts longer than 2 weeks or if it keeps coming back, you have to get it checked out. That's when the serious complications can start.
So what are the treatment options when it doesn't clear up?
If it's allergies or congestion, a doctor will always start with the simple things. A steroid nasal spray, maybe a decongestant or an antihistamine to get that inflammation down.
And if that doesn't work and there's fluid just sitting there?
Then you move into minor surgical options.
Let's walk through those.
The quickest fix for fluid is a tympanic incision or a myringotomy.
Sounds scary.
It's really not. It's a tiny little cut in the eardrum to suction out the fluid. It just lets the middle ear drain and ventilate. For adults, it's often done right in the office.
And it heals up fast.
Very fast, usually in just a few days.
And for kids who have that ongoing anatomical issue?
That's where you see pressure equalization tubes or ear tubes. It's the same idea, but a tiny tube is placed in the incision to keep it open for several months, letting the ear ventilate continuously while the child grows.
And what about for adults with chronic blockage? I read about something with a balloon.
That's a newer procedure, balloon dilation. It's for select cases, but they can actually thread a tiny balloon catheter up through the nose into the eustachian tube.
Wow.
They inflate it briefly to stretch the tube open, kind of resetting its function.
And the relief from these procedures is pretty much immediate, right?
It's very fast. The pressure is gone, so the pain, the fullness, and very often the associated tinnitus improve almost immediately or within a few days.
So to wrap this all up, we've taken a deep dive into this tiny 36-millimeter passage.
We have.
And it's clear that ETD is a major cause of ear trouble, linked to everything from a common cold to stress.
And critically, the type of tinnitus you experience, that roaring from pressure versus hearing your own heartbeat from an open tube, is a direct clue to what's going wrong.
The big takeaway here really is that this is so often treatable.
And temporary. That's the most important message. You don't have to just live with the pain, the fullness, or the tinnitus. If you get the underlying anatomical issue diagnosed, it can often be fixed.
We've seen that altitude, allergies, even anxiety can trigger this. And since the early symptoms feel so much like a simple cold or allergies, it really leaves us wondering, doesn't it?
It does.
How often are persistent ear problems just brushed off as allergies when the real culprit is the mechanics of the eustachian tube itself? It's a really compelling reason to ask your doctor for a specific test, like tympanometry, if your symptoms just refuse to go away.
Something to think about.
Something for you to explore on your own. Until next time.